Hi, everyone. Welcome to the SAEM Research Learning Series course online lecture titled Using Qualitative Research Methods to Better Understand and Address Social Determinants of Health in EM. As we begin today, please write down and save any questions you may have for the end of the presentation. You can enter your question into the chat box or unmute yourself during the Q&A portion of the lecture. This lecture is being recorded and will be available shortly following today's session. And now it is my pleasure to introduce to you Dr. Anna Tupetz and Dr. John Purakal. Dr. Anna Tupetz is a postdoctoral fellow within the Department of Surgery, Division of Emergency Medicine at Duke University School of Medicine. She works clinically as an acute care physical therapist within the Duke University Health System. Her research work within the Duke Global Emergency Medicine Innovation and Implementation Research Lab focuses on the challenges and factors impacting access to quality care from the patient as well as provider side, with a special attention on mixed methods and qualitative study designs. She is especially interested in the impact of short and long-term disability and how it impacts social determinants of health. John Purakal is an assistant professor of emergency medicine at Duke University School of Medicine. His research interests include screening for social determinants of health, racial and ethnic disparities of emergency care, and screening for unmet needs. He is the founding editor of Social Impact, or Social Impact, an educational forum for collaboration, advocacy, and education related to social emergency medicine. With a passion for teaching, Dr. Purakal strives to find innovative ways to educate both residents and his patients' communities. He has a track record for developing interdisciplinary public health educational initiatives geared at reducing gaps in knowledge in at-risk populations. Most recently, in 2020, he was awarded Faculty Teacher of the Year by the Duke University Emergency Medicine Residency Program and was awarded the COVID-19 research grant from the Emergency Medicine Foundation. Dr. Tupetz and Dr. Purakal, I will now turn it over to you.
Okay. Thank you very much for the introductions. It's a pleasure to meet you all. So as John already mentioned, today we're going to be talking about ways to better understand and address social determinants of health in emergency medicine. So just to give you some objectives, we will start by giving an overview of social determinants of health. Then we're going to get into what qualitative research is, how and when to use it, and then go a little more specifically into qualitative research within the setting of emergency medicine, what challenges there might be, but also what opportunities it holds. And then from there, we'll transition into a little more specific, the social determinants of health and qualitative research. And then concluding, we're trying to bring it all together and hopefully leave some time for questions.
All right. Hello, everybody. So social determinants of health, as you may or may not already know, there's the WHO definition of it that's been kind of regurgitated over and over again for the last 11 years, that these are the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. So there, the definition here is wide ranging, and it has been shown that there's changes in life expectancy depending on where you live, right? There's lots of evidence pointing to that. Specifically, I've spent some time in Chicago, and there was a 6-mile a 6 mile area that, if you looked at downtown Chicago versus South Side, that you would see a life expectancy change of like over 10 years, right? And so that's largely attributed to these non-medical social factors that we believe are playing a role. Additionally, housing instability and food insecurity have been associated with increased emergency department utilization, as well as hospitalizations. So regardless of the definition you use to define social determinants of health, the core principles remain essentially the same. And you can see here are 4 of the most cited definitions for social determinants of health. These are factors that are commonly underappreciated as key contributors to health outcomes. And if given the appropriate attention and resources, may be more easily modifiable than the biological determinants of health that we as providers spend a lot of time trying to improve for our patients. If you focus your attention to the middle column here on the screen and look into the blue row, you'll see discrimination, and you see it again at the bottom and the bottom row as well. And just to give you some idea of how expansive these definitions are, right? Discrimination, I mean, we know that bias in medicine and bias in healthcare affects every facet of our patients' lives. We know that there's racial and ethnic biases towards how we dole out pain medicine, right? How we identify myocardial infarction and recognize stroke. And we know discrimination plays a role in access to care and issues with our LGBTQA patients as well. So you can see how even in just one bullet point, right, in one of these columns, how wide-reaching and expansive the research opportunities are there, and how much more we have to do to start adequately addressing these things for our patients. But before we can delve into using qualitative research specifically to explore social determinants of health in the emergency department, let's review what we know about social determinants of health and their role in healthcare. So why are these relevant to us as providers and researchers? Well, first, let's look at the outcomes of unmet need. Here we see just a few examples of the many impacts of these non-medical factors on both the patient as well as the healthcare system. The effects, again, are wide-reaching, and with many factors we as providers don't routinely take into consideration for screening, or when we work up a medical condition or even come up with a treatment plan for a patient, we may not necessarily be thinking about all of these different factors, whether it's language, access to language services that account for a high ED utilization rate, food insecurity, unemployment. These are things that, if you start to consider as part of your workup and part of your plan, you may end up, finding there's a lot of opportunities for improvement. And so this is one of the many reasons why this is becoming such a large area of interest, both at a research level, right, at an individual researcher level, but also all the way up to the national and federal level. And here's why. So we're going to go over five things you need to know about social determinants of health in healthcare. So first, social determinants of health are greatly influenced by policies, systems, and environments. And so in this diagram, you can see this is by the county-based health rankings and roadmaps. It shows the interaction between health outcomes, the determinants of health, and policies and programs. You can see the bottom left corner there is where policies and programs kind of start us off. So for example, tobacco, right? Leading cause of determinant of health outcomes such as mortality and quality of life. And decreasing tobacco use is more influenced by the price of cigarettes and smoke-free environments in the community rather than the availability of clinics for cessation or quit helplines. And so that's an example of kind of programs and policies that can impact kind of social determinants of health downstream. As a determinant of health, medical care is insufficient for ensuring better health outcomes. So medical care is estimated to account for only about 10 to 20% of the modifiable contributors to healthy outcomes for a population. The other 80 to 90%, you can see the breakdown here in terms of the multiple modifiable factors on this image and their relative contributions to both length of life, measured in premature death, quality of life, and then as well as quality of life, which is measured as low birth weight, poor mental or physical health. And so, we as a country spend a significant amount of money on our healthcare system, but we don't necessarily spend an adequate amount or a disproportionate amount on addressing social needs. And we know that our health outcomes are kind of middle of the road and definitely not adequate compared to how much we spend on healthcare as a country. And so you can see here just a breakdown of kind of the multiple modifiable things, and obviously non-modifiable things like genetics aren't included on here because at present time we are not able to modify genetics. So, all right, moving on. Number 3. Data frameworks have been proposed for integrating social determinants of health into primary care and capturing SDOH domains and electronic health records. So you can see here a number of different examples of different screening techniques that are utilized for evaluating social determinants of health. For example, the frameworks may not yet include how the data might be used with community partnerships to expand the effect of collecting data. So screening tools are really only as useful as the objective data that you're collecting there. But there's a lot of opportunities and nuance and details that's missed in these screenings, and a lot of times we have concurrent social determinants that are unmet, right? And so there's got to be a relationship there that we're not fully evaluating just with screening. But the point being that social determinants are now being integrated into data frameworks and being integrated into electronic medical records. And now what we do with that as a next step is kind of very key. New payment models are prompting interest in social determinants of health. So alternative payment models, accountable care models such as ACOs, patient-centered medical homes, Medicare shared savings. These are all moving towards payment models that are going to reimburse more based on better health outcomes. And because we know that social determinants of health lead to better, or addressing unmet needs and social determinants of health lead to better health outcomes, all the different payment models are starting to shift towards payment scales based on the health outcomes, preventative medicine, and addressing social needs via screening and other opportunities. Specifically, and then moving on to number 5, I kind of talk about 4 and 5 here. Experiments are occurring at the local and federal level. So state innovation models are exploring connections among healthcare, social services, and some social determinants of health. And so as a response here, the state and federal levels are looking at ways, not just ways for reimbursement that we just talked about, but also kind of ways to help alignment and coordinating care. So in North Carolina specifically, we have the Healthy Opportunities pilot, which is essentially statewide, starting to incorporate social determinants of health screening on these 4 domains on the bottom left here: housing, food, transportation, and interpersonal violence. And then, obviously developing pathways and community partnerships to address those. But they're already rolling that out in the primary care setting across the state. Further, on again, talking about alignment and collaborative solutions for these kind of complicated multifactorial problems, NC Care 360 is a state platform. It's the first statewide coordinated care network to electronically connect those with identified needs to the community resources, as well as allow for feedback loops of communication, checking in to follow up to making sure the patients are able to get the resources that they've been referred to, and so on. So Duke is the first emergency department to utilize NC Care 360 in the state. And so we'll obviously have more on that, but you can see how, this is now being built into every aspect of our healthcare. And that's why, again, kind of bringing it back to qualitative research, why it's so important. And so over the last 15 years, governing healthcare bodies have made recommendations with regards to increased focus on promoting research on social determinants of health. With so many unknowns about the use of social determinants of health in clinical care, having data for measurement and evaluation of interventions is really essential. And you can see here kind of 3 separate recommendations over the last 13 or so years that have talked about kind of focusing attention and energy and resources and funding towards social determinants of health. Despite the obvious value of research, these efforts rarely offer insight into the complex, layered, and multifaceted social, economic, and political factors that shape health disparities. And so, because our quantitative research can only do so much, and because we, just like we look at any other medical issue or kind of any other area of research, there is a role that qualitative research plays, and maybe no more so does it play an important role than in social determinants of health, because of the amount of nuance and detail and personal kind of variability that can come with these very, very personal issues, right? And so, and that is why, that's kind of the crux of where qualitative research is so utterly important as we move forward as clinicians and as researchers into this realm of advancing social determinant or social medicine. So, so to speak, that we have a qualitative component to the research that we're doing as well.
All right, thank you, John. So let's start with the basics on what qualitative research is. First of all, of course, it is non-numerical data That might be the biggest or most striking difference between quantitative and qualitative. It is the whys and the hows of human behavior, opinion, and experience. So really to define it, it is how people make sense of their world and the experiences that they have. It is not only a survey, it is also not designed to quantify information, but it is also important to note that it is not purely objective. The researcher is going to be part of the study process, and we'll go a little bit more into detail later on. So most of us know qualitative research as interviews or focus groups, but it can also be something like natural language processing. It could be community-based participatory research, community mapping, action research, text messaging, analyzing personal documents, using art as a form of qualitative research. So you can see it has a lot of facets to it. All right. Or how Twitter would call it, qualitative research and quantitative research could also be exactly that. All right, great. So the first question to answer is, can qualitative research studies generate high quality evidence? Short answer is yes. However, there is not a strictly determined right way, and that is because we have to think about reflexivity, subjectivity, and bias. So reflexivity means that we need to be mindful and also acknowledge your own role as the researcher in the process of qualitative research, and also what research relationship you have. Subjectivity means that you are encouraged to reflect on the values and the objectives that you as the researcher are bringing to the research topic. And then bias is what we know from quantitative research, of course, is any influence that provides a distortion in the results of the study. So that's something we have to think about. There are there's several quality checklists that we can use. One is the Critical Appraisal Skills Program, and I'll go a little more into detail to that. And then there's also a reporting guideline, like we know from systematic reviews or quantitative studies. And that one specifically is called the CORIC guideline, and that will talk you through what parts of this, kind of gives you a checklist of what needs to be fulfilled to generate a high quality qualitative study. All right, great. So here's one example of a study that John and I and our research team just conducted earlier this year. It is COVID-19 infection experiences and social determinants of health in North Carolina. So our study objective was to explore patient perceptions of the influence of social determinants of health on their COVID-19 infection experience, and also COVID-19 transmission within their communities. So let's use that as an example as we kind of guide through the rest of the study. All right, so this is the CAST tool that I introduced a little earlier. And those are just some guiding questions that I want to go through with you to see how you can decide if qualitative research is even appropriate, and then having some guiding questions on how can you assess if a qualitative study is of high scientific rigor. So the first one is, was there a clear statement of the aims of the research? The second one is, the qualitative methodology appropriate? And that's a really important question, because there is always a need for a certain design, right? So it might be that you have a study question that simply will not really be appropriate to be answered by qualitative research. Then the next one is the research design appropriate to address the aims? So that means, like I said, in qualitative research, we have interviews, we have focus groups, we have all sorts of different data collection tools that we can use. So we need to decide which research design is really appropriate. And thinking about the recruitment strategy, and we'll go a little bit more into detail on that later on as we keep talking through our study. The recruitment strategy is something that is really, really important to think about from the very beginning when you start designing the study, because that will that will really influence not only, you know, who you talk to, but also how are you accessing your study populations. All right, was the data collected in a way that addressed the research issue? Again, it depends on, as I said earlier, the researcher is going to be part of the research study, right? So you need to really think about how and who is collecting the data. Leads me to the next question. Has the relationship between researcher and participants been adequately considered? Meaning, especially when we talk about clinical research, who is the person conducting the interviews? Will there be any specific power dynamics maybe, right? Do the participants maybe feel or could feel coerced in any way that they think there is a connection between the medical treatment that they receive and then also the research study? So that's going to be very important to distinguish and be ethically sound. Which brings me to the next question: have ethical issues been taken into consideration? Very similar, of course, to quantitative research, and that's something that we strive to in every research activity that we conclude. Then, was the data analysis sufficiently rigorous? And we'll go through the data analysis a little more in detail later on, but especially here because, like I said, qualitative research, there's no clear-cut right or wrong way to do it. You still can and should have high scientific rigor. And then, do we have a clear statement of the findings and how valuable is the research? So those questions are really helpful to think about, if you are planning on conducting your own qualitative study, but also having that as a guideline as you are maybe reading qualitative studies as well. Great. So let's talk a little bit about the analysis approaches after you have collected qualitative data. So we have the inductive analysis and deductive analysis. Inductive analysis means that you develop a model or a theory and that the themes and the codes are emerging from the data that you have gathered in your interviews or focus groups. Deductive means that you're using this analysis approach to test or confirm a theory. So the themes and codes are predefined. After you've done that process, usually in a team, you're usually writing analytical memos. Memos is a way of examining, interpreting the data, and it also helps you to understand better the relationships between the findings and helps you to explore certain hypotheses, not only per the individual, but also per population group or per themes that come up. And it's a really good basis to really dig deeper in the understanding and having a foundation for discussion with the rest of your team. All right, next slide. So how does data analysis, or how can data analysis look like in qualitative research? You can see here participant A, B, and C. Those could be, for example, interview transcripts that we have. We're then using this data that we gathered and code them into different themes, which is the unit of a meaning that is observed in the data. So a theme is kind of your overarching topic. Then a code is a component of a theme, right? So you can see you kind of get that coding tree where you can break down those themes even further. Then you have the code book, which is a structured way to compile the codes, including a description of what the codes are and also how they relate to each other, and potentially giving examples, mentioning what would be coded under this specific code and what would be excluded as well. So the code book is going to be essential to really think about. You want to have a structured and standardized way that everyone could code this interview and would come up with the same with the same results. And you have that as a basis for discussion with your team. All right, next slide. So let's go back to our example from the qualitative COVID-19 study that we conducted. before we even started with the analysis process, there was a lot of preliminary work that needs to be done in the study design, and then also setting up not only the data collection and all that, but also thinking about how are you going to be structuring the team that is working on that study. So the first step for us was to have team trainings to bring everyone on the same page on how to conduct interviews, what questions to ask, how to ask questions, how to build rapport with the study participants, right? All those things are going to be really, really important. And you also want to make sure that you have everyone is kind of on the same, on the same page when it comes to the interview guide, so that the interviews that you have are going to be comparable, right? So we had several team trainings on what qualitative research is, and then also how do you develop an interview guide that we all did in the team, and then using that continuously as quality control and making sure, reading through the transcripts, listening to the recordings again, discussing if there's any feedback that we can give, and make sure that the process of data collection is as rigorous as it can be.
And I'll jump in real quick because I recall, as someone who's not as proficient in qualitative research as Anna is, Anna spends a lot of time doing this. One of the more useful things in this kind of preliminary process was the kind of the mock interviews that we did with, it was data that we weren't going to use for the study, but it was essentially, we went through the entire interview that we had developed with somebody who fit kind of some of the profile that we were looking for, and we went through it knowing that this was just a trial run essentially, and it was that was really helpful too, because then these are questions that you're not certain what responses you're going to get to them going in, and you can kind of imagine, but it's good to help you kind of tailor things afterwards. And we kind of reconvened after we had both done our pilot interviews, to myself and Justine, who was the other researcher that was doing this with Anna and I, and talk about kind of what we noticed and how can we change things, and what minor adjustments need to be made so that we can kind of get more out of the patients, allow them to kind of tell us more of their story and let them drive the ship, so to speak. So I thought that was really, really useful. Sorry, I'll let you continue.
Yeah. No, that's a really good point. And the thing also is with the interview guides, it is different to a survey that it gives you that flexibility, right? You want it to be a conversation and a discussion between the researcher and the study participant. So it gives you flexibility. However, it also is a guide in a sense that you want it to flow nicely, that it allows for a conversation. So I think also having the piloting sessions with volunteers who are not patients and not, as vulnerable, that we expose them to any sort of risk, helps to really understand how the questions flow, if the wording might need to be changed, and all those things. All right, great. On the corner here, you can see this is just an example of our coding logbook after we finish data collection. How do we then take the next step and say, okay, we have the transcripts, now we need to develop a code book. And you can see kind of how many reiterations we went through, team discussions, having several people coding the interviews, or some of the interviews, combining them, comparing them, until we come up with a code book that was valid and that seemed to really capture what we're trying to capture. All right, great. And then the next step, after we had developed our code book, and after we coded all the interviews and had, again, team discussions to make sure that that the content is right and that we all interpreted the findings a similar way, we were focusing more on writing those analytical content memos. And we'll have a few examples later on, but content memos are a great way to really condense and reflect and interpret the findings that come up per theme, for example, right? So one theme might be the experience of getting a COVID test, right? So then we can compile everything that we find on that theme and try to break it up into subcategories and really trying to understand what we can find and what we can learn from that theme. Again, it's a really good way to have that as a basis for team discussions, potentially also bringing that back to participants to get some participant validation and content validation. All right, great. So going back to qualitative research in general, I think what we really need to keep in mind, which is very different to quantitative research, our findings are going to look a lot more like understanding certain beliefs or perceptions or identifying challenges, hearing more about opinions, experiences, suggestions, those things. So it can seem a little more abstract, but it is giving more context to understanding challenges that quantitative research might not be able to capture in that sense.
So we've talked a lot about what qualitative research is and kind of the nuance of developing a team and going through that process. For social determinants of health research in general, you can imagine how difficult it is for some of these topics to really use a quantitative approach and really come to a full understanding when you're talking about interpersonal violence, when you're talking about housing instability, recurrent housing instability, right, or unstable housing, food insecurity. These are topics that aren't necessarily always so straightforward as objective lab values and things like that. So, qualitative research provides a more in-depth understanding of the factors that shape health and behaviors. It provides insight into these processes and which of these factors shape health and disease. It gives you a more contextualized understanding of the interventions and what actually works and doesn't. And then it provides opportunities for theory building and testing. And it just brings into sharper focus the subjective meaning of health behaviors and psychosocial determinants of health and interpersonal determinants of health that have played important roles in refining health behavior theory and practice. And so it just gives you another holistic way to thoroughly evaluate something that really requires both quantitative and qualitative research to kind of come to a better understanding. And we're not there yet. I think it's, the pandemic, if the pandemic has proven anything, is how it magnified all of these unmet social needs that maybe people who attend lectures like this maybe were privy to, but the rest of the world didn't really quite understand how these social needs really drastically impacted areas of or infection rates, right? And we saw that in the pandemic, those that were essential workers, those that were working in healthcare, those that were in multi-generational homes, how they were the ones affected early and often in the pandemic. And so that really kind of brought it to light on a national level, but we understand why that is, and I guess all of this is to give us a better kind of more bird's eye view, as well as a more contextualized view of what we're talking about when we talk about social determinants of health.
Great, thank you. So that brings us to the emergency room as what we think probably an ideal setting for social determinants of health research and integrating qualitative research. So qualitative research in emergency medicine has several opportunities. It allows us to really understand the challenges and needs of very diverse population groups that are served in the emergency room. It also helps us to understand the challenges and needs of ED staff and the work practices. We can identify areas for improvement and growth, and we can develop and implement targeted interventions. So the setting of emergency of the emergency room, this might be usually an access point, and maybe also the only access point for several population groups that otherwise we would not have the ability to really learn about their challenges and their needs, right? So let's keep that in mind. And then we'll go through a few examples on how qualitative research has been used in emergency medicine. And we have all the references to those studies later on in the recording as well. So this one here is a purely qualitative study that helped us to understand patient health seeking behaviors. And it was conducted in order to really inform interventions and reducing the burden on ED with non-urgent care needs. So as you can imagine, implementing interventions that reduce the burden on the ED is critical to really be able to serve those who need the ED as efficiently as we can.
This example is actually one of the studies that I was lucky enough to start working on when I was in medical school. I was working with Dr. Philip Levy at Detroit Receiving, and we actually did a 3-country study looking at explanatory models of hypertension in the United States, in Kingston, Jamaica, and in Ifakara in Tanzania. And so, this was a really interesting qualitative evaluation because we were exploring disease knowledge in ED-specific patients with chronic hypertension using qualitative analysis, comparing gaps in their knowledge across racially similar but geographically divergent patients. And it gave us really good insight into, kind of the cultural competence you have to have too when dealing with kind of going across geographical spaces, right? So not even necessarily country to country, but having moved from Chicago to now being in North Carolina, there's just nuance in dialect, there's nuance in what people mean when they say certain phrases. And so we saw this on a much larger scale, interviewing patients and kind of, number one, going through all the things Anna talked about in team development, quality control, making sure that our interview questions ask the same thing in those 3 different cultural settings, right? And especially when you translate to Swahili, making sure that the question that you're asking means the exact same thing. So you have to have a very, fluent team in kind of the cultural nuances of the population that you're looking at. And then making sure that, the way that we went through and coded all of these responses, right? Again, you have to translate it all back into English, or at least have the people who are fluent in that language be with you when you're going through the responses, to make sure that how you translate it back into English would make sense to the person that actually said it in their native tongue. And so you can see how this is like it was a very cumbersome process, and we didn't even use NVivo. We were using Excel for the majority of this. So it was a very, cumbersome project, but it was extremely interesting. We found out a lot of the social and cultural determinants that were playing a role in people's chronic hypertension and how they looked at hypertension, in the religious aspects that may play a role in how they manage hypertension and the barriers to caring for their hypertension. So it was this is just one example, again, of using the emergency department and doing a qualitative analysis that really draws, yes, we're talking about a medical diagnosis of hypertension, but you can still, within that, the responses were majority were made up of different determinants of health and cultural variability between these 3, again, racially similar but geographically divergent patients.
All right, great. So let's talk a little bit again about different research designs and get a little more theoretical again. So mixed methods research designs have, in my opinion, a great opportunity in emergency medicine to really, use the quantitative research designs and qualitative research designs and really help us to gain a good understanding of the challenges that we're facing. So the explanatory mixed methods means you explain or better understand results. So as you can see here, you start with quantitative data collection and results, and then after that you add a qualitative component to the study to then help to explain your quantitative findings. Right. So if you think about implementation science, for example, or intervention development, right, in terms of feasibility trials, for example, adding this qualitative component could really help you understand why you have certain outcomes that maybe were really unexpected, or better understand certain population groups within your quantitative sample. So then we have the exploratory mixed methods, which means you first use qualitative research to explore and then develop an instrument or design that you can scale up and use quantitatively to access a larger population group. So then the qualitative component here is really going to help you to first look for or understand what you really should be looking at in a more quantitative way. And then we have the triangulation mixed methods, which means you have your quantitative component and you have your qualitative component, and you use both those findings to then interpret and make sense of what this all tells us. All right, so the next slide is going to talk. This is just a very brief article actually that I encourage you to read that talks about how mixed methods can really be used in emergency medicine to answer key questions, right? Because it's not only going to tell you of how many, but it also will give you an answer and an explanation to why you have those findings. This mixed method study is a great example of how quantitative data from ED patients were used to compare delay of patients who were boarding in the ED. So they already have been deemed to be admitted, but were held in the emergency department until admitted. And then they used qualitative interviews with providers to understand potential reasonings behind the quantitative findings that they found. So this study shows that quantitatively, it seemed like there would have been a need to implement a certain intervention to speed up that admission process. However, the qualitative findings then have found that culture, resource availability, and all those key components from the provider side, which we could not actually have gathered quantitatively just by looking at the health records, told us that just implementing that intervention is probably not going to actually change those numbers because you had so many contextual factors there.
Okay, and before we jump into the opportunities and challenges, with qualitative research in emergency medicine using social determinants of health, why is this the ideal setting? Well, we have significant need, and so in one study that was performed surveying 269 patients that ended up completing the study over a 48-hour time shift period. They found 37% of their patients had social risk, 31% of their patients had active acute social needs, and of that 31%, 54% had more than one social need. And so you can see how that is that's a very large proportion, right? We're talking about a third of our patients fall somewhere between, social risk or acute social needs in the emergency department and an urban setting. And so you can take this and you can apply it to almost every setting. I've worked in Detroit and in Chicago, and now being in Durham. I mean, it doesn't matter where you are in the country, there is some level of social need that is going unrecognized. And the studies have shown that it's anywhere from a quarter to a third of our patients. And so this is why the ED is an ideal setting to be doing the qualitative research that Anna and I have been talking about and looking at social determinants of health.
All right, great. So just to recap on some of the challenges that qualitative research in EM and also thinking about social determinants of health might bring up is the study timeline. So you really need to think about how and when are you going to collect the data. Qualitative research, the planning and then the analysis process does take a long time, even if it is just a one phone interview, for example. Just that process of recruiting participants, doing the interview, and then analyzing does take a long time. Especially in the ED setting, think about power dynamics. Again, if you choose to interview patients that are currently in the waiting room in the ED, for example, we'll have to think about power dynamics and making sure that they don't feel coerced to participate. All the other ones we kind of already talked about, the role of the interviewer, the training, thinking about the potentially vulnerable population sensitive topics is going to be critical. And then also thinking about language options and cultural considerations, again, because the ED we do see a very diverse group of people. So we'll have to make sure that, yeah, the cultural considerations are met. And then also, for example, if you choose to interview patients in Spanish, that the interview guide is appropriately translated and validated. Other challenges when we think about data collection and analysis in the ED setting specifically is the privacy and safety of the participants, noise and distractions. People are there to receive care, so you might, you'll need to make sure you have the space and the room to do that. And building rapport is going to be important, especially when patients or participants are just there once. How are you really going to be able to, or what is your approach to really help to build that rapport, that they trust you and feel comfortable in that? Okay, and the next one then, we're talking about the opportunities though that qualitative research holds, and it is that it helps us to better understand the setting and the location of the specific challenges. Generally, what we found is that it is an accepted place of data collection. We can learn about barriers to receive adequate resources, and it also helps to really facilitate the interdisciplinary approach. When we think about intervention development, implementation science, and quality improvement, having that setting in emergency medicine and qualitative research can really be a good addition.
And I'll add on there that in terms of it being a generally accepted place, we were presenting some results at ASAP coming up here that show that more than 50% of the patients that we surveyed when we were asking about patient perceptions for screening for social determinants of health, that patients were very okay. More than half of the patients were okay with the emergency department being the place where this gets done, right? Addressing social determinants of health and asking questions about social determinants of health. And the majority of them were okay with, even so far, and I know this is outside of the qualitative research aspect, is saying that they'd be okay with waiting for a social work consult, even if it delayed their disposition and if they had to, to go home. So this idea that maybe it's not an ideal setting to address social needs is showing up, at least in my experience so far, to be not accurate, and that patients are okay with it, and a lot of times this is their medical home, and so that if these issues are going to get addressed somewhere, it's going to be the emergency department.
Great. So just briefly, because I do want to leave some time for questions, just going back to our example from the COVID-19 and social determinants of health study. Some challenges that we faced and then potential solutions offered was the development of the interview guide and how to ask questions about social determinants of health without being leading or expanding over what a survey would otherwise measure was I think a challenge or a discussion that we had to have in the beginning across the team to really just make sure we're not kind of just ticking the boxes of, let's go through each of the social determinants of health, but asking questions in a way that we really understand what challenges they might be facing. Identifying the study sample and then also the recruitment was tricky because we chose to do phone interviews of patients that have been discharged. So basically cold calling patient or participants, again, that is kind of like the study timeline, right? That might take a while until you get enough participants wanting to talk to you. And then potential language barriers, making sure that whoever you are calling, that you have someone on the phone who can speak the appropriate language for them. Another thing also that I do want to mention is when you do those studies, you also need to make sure that you have the institutional support and also the resources available to really use the findings that you have to put them into practice if you do find barriers or challenges that you want to address as well. All right, and then John is going to go a little more into
Yeah, just very quickly. So for those that haven't actually had experience doing this before, and I had never used in vivo before this study, but you develop these nodes, if you will, which were essentially kind of the response, any response that fell under one of these nodes, as the reviewer, we would go through and kind of file them under one of the categories you see here on the left. So, COVID communication, infection status, diagnosis, infection experience. You can see how, there's a ton of different things that we can look at from both an infection standpoint, and then as well as from the social determinants that played a role. And then from there, we developed the analytical memos that Anna had been talking about. So here are just 3 of the examples, and we had I think a total of 10 memos that we came up with total. But the theme for the first one being prior knowledge of COVID, and the sub theme being perceived risk of getting COVID prior to actually becoming infected. And just kind of come up with a summative, succinct paragraph to really summarize a few of the quotes, and then you move on to the next sub-theme. And so similarly here, you see in the other one for COVID-19 impact on daily life, and then again, disapproval of government's handling of the pandemic under the theme of suggestions to improve pandemic response. And here are just very briefly some quotes, that we got back, and you can see again how this provides just another view into a problem that we know plenty about. We've been living in this in real time, but you can apply this to anything else. But you can just see how these responses, some of them are expected, some of them maybe less so. But one person kind of talking about the delay in handling, or the delay in kind of approaching this in a serious way from a government standpoint, when you're talking about the government response. The next person, when talking about ability to isolate, talking about how he was an essential worker in the mailroom, and how he never got to isolate. People need their mail, so he always had to go to work. And you can see how he attributed that to why he thinks he got COVID. Finally, this is a really interesting one on the communication of infectious status in general. When we asked about whether or not people shared with others that they had gotten COVID, you had one side or one group of people that said that they didn't tell anyone, that they thought it was taboo, that there was a kind of almost a negative stigma attached to it, with the idea that people might think that others that had gotten COVID, maybe they got it from this person, or so on, right? And then the second response said, yes, I told them. Yes, I did. I tried to make sure I wasn't around anybody, which I wasn't. I was going to let everybody know, because one of the issues about the spread of COVID is that people be knowing they have it and not telling people. And I feel like that just don't make sense, because I feel that's why we are still going to be in this different norm. It's not like it's AIDS or anything. You have to let people know so we can try to end it. And so you can see how these quotes are extremely powerful, right? And show variations in the level of understanding of the disease process, and how you can't necessarily get a response like that, or get an insight into someone's experience with COVID and kind of their understanding of the disease process without having a qualitative component to it, especially something that's going on in real time when you're trying to come up with interventions that are community specific or even neighborhood specific. It adds just a different layer of understanding that you won't get otherwise. So in conclusion, we've talked about how addressing social determinants of health is an integral part of clinical practice, and how moving forward it is just going to be part of what we do, not just in how we are repaid from an insurance status or insurance standpoint, but also in how we perform research, in incentivizing research and funding and resources, as well as alignment of community partnerships. The ED is a unique setting to conduct research on social determinants of health, and especially qualitative research. And so far, in my experience, has been one that has been unique, but also not as difficult as you might think. A lot of the barriers that people perceive about performing this research in the emergency department, that's not always the case. And we found that even when we were cold calling patients that had been diagnosed in the ED, and that in that particular study, yes, getting them to answer the phone was difficult, but once you got them on the phone, they were willing to talk. And there weren't a lot of people that refused the study once you actually got them on the phone. It was just the unrecognized number component of it that was really a barrier for us. Qualitative research provides patient-centered view of a multifactorial problem. There's obviously great opportunities in what is a pretty considerably new field in terms of social emergency medicine, with its own challenges. Your design must fit the research question, and qualitative research allows us to invest in long-term support and capacity building to inform change. And so with that, we will open it up to any questions, and we thank you for your time.
All right, Dr. Tupetz and Dr. Purakal, thank you so much for this very informative presentation. I'd like to open it up now for Q&A. You can unmute yourself and ask your question at this time.
All right, we have one question here on the compensation for participants. So thinking in our study, the one that we conducted over phone interviews, we did offer compensation. However, we only would inform patients that they were getting compensation after we introduced the study to them. And I think in our case, it was $30 per phone interview, if I remember correctly.
Yeah, and there were barriers even within that, challenges within that, and I think that because every institution is different, right? And if you are, I think ours was coming in the form in the form of like a prepaid credit card through the institution, and that because it was coming institutionally, you had to get a tax ID or social security number from the participant. So again, you would think, and that when we heard that, we were like, there's just no way. There's no way we're going to get anyone to participate in this study that has to, if we're saying compensation is only if you provide that information over the phone to a complete stranger that you're trusting is the person that they're saying that they are. And I will say that I think the people that I interviewed who went on to not want to give their social security number or tax ID over the phone still completed the study. They just did it without compensation. So we didn't find that to be as big of a barrier. Again, I think the biggest barrier for us in that particular study, because it was a telephone-based like cold calling people outside of their diagnosis in the ED, that particular study the challenge was actually getting them to pick up. But this financial one, even though there was a significant barrier there, it didn't end up being one for us.
Thank you. That's really helpful. Sorry, this is Karen who asked the question. I think as a follow-up question, is there any sort of like standard protocol, some sort of like way to figure out if I'm going to interview a patient for X amount of time, it should maybe be X amount of money, or, kind of like we do for per diem, meals almost.
Yeah.
They're kind of these kind of national guidelines.
That's a great question. Anna, do you know?
So I think it depends kind of on your own IRB regulations as well. I'm not aware of a specific guideline of saying 30 minutes should be $30 or something. The feedback that I got just communicating with our IRB office on compensation amounts was that it still needs to be somewhat reflective of the time commitment, if you see it as a like salary or a job, right? So if you have a patient or a study participant who and you would offer like $100 for an hour, right? That would be considered like coercing the participant to conduct the study, because he actually would benefit of it, other than just compensating for the time that they're giving. Does that make sense? So to me, what I found is that generally they want to stay on the lower side, to just say, okay, it's kind of like a work hour that you give some comparable compensation, but not anything that would positively influence their decision to participate.
That makes sense. Thank you.
Let's see. The next question here is, how did you get consent to call? Did you get consent when they were in the ED? So no, this was all retrospective, and we had a database that we had pulled for a geospatial mapping study that we had used. And we've basically identified patients by figuring out where the area of the highest infection rate were around our hospital, and then decided to use those areas as kind of our focal point for cold calling. But we essentially had patient lists based on that, and our IRB clearly specified that we were essentially cold calling these patients. We had a script that we had to submit, obviously, to the IRB that showed that the first line is, I'm calling from Duke University. I'm calling about a research study involving social determinants of health and COVID-19. I was wondering if you'd like to speak to me more about that. And if they were interested, obviously you proceed with kind of your introduction, and you go through your consent process the way you would with an in-person consent process for any research study. And then, like Anna said, towards the end of that, if they had already said that they were interested in kind of moving forward, or we essentially asked them, are you interested in hearing more? If they say yes, we continue. And then at the end of that spiel, we would say, and there's also offered compensation. This is how much it is. Here's what you would have to submit to get that compensation, and then allow them to make the choice to be in the study with or without compensation, or not be in the study.
Just to add on that real quick, given that they were all prior patients, we had information in their medical charts if they already pre-consented to be approached for research studies. So if patients were declining any sort of contact, we would not have been allowed to call them and to cold call them.
Yep. All right, 1 o'clock on the dot here.
Just want to give a last call for any additional questions. Okay, well, Dr. Tupetz and Dr. Purakal, thank you so much for an excellent presentation. And thank you to everyone who was able to attend today's session. Have a great day.
Thank you.
Thank you very much. Bye-bye.